this computer. Beautiful. Ciao. Tell me about yourself, man.
Well, I'm a student at King's College London. I'm currently writing my dissertation on direct primary care and healthcare reform in the US. And
Great.
since I know very little about healthcare and the perspective of a physician, I started reading and researching more. And your TED Talk showed up on my feed, and um, one thing we have in common is that I was also born in Detroit, but I actually never got a chance to go back. I left when I was only one. So
Wow, that's awesome.
I should have an interview with you. So I reached out and you said yes, and here we are. And yeah, I was wondering if I could start by asking you some questions.
Yeah, of course, man. Let's do it. Happy to answer any questions you got.
Great. So just a little summary about kind of the content of what I'm going to ask. I'm going to ask a little bit about health outcomes in general of direct primary care compared to traditional insured care where you don't have a primary physician. I'm also going to ask a little bit about cost, particularly why it's so much cheaper and more accessible in that sense. And lastly, just some more general questions about the movement of direct primary care. I'm aware you don't represent the movement as a whole, but still, it's very interesting to have your perspective on that.
Sure.
So the first question that I have, speaking of health outcomes, is um, for the most preventable kinds of diseases or things that mostly lead to hospitalizations, um, what kind of care do you provide that prevents these urgent care needs that someone who didn't have primary care would end up having to go to the hospital for? What's the most common preventable thing that you deal with in your day to
Sure.
day?
Yeah, there's like a number of preventable conditions that people come to our office for care for. Like for example, a really common one is diabetes. If you have type 1 or type 2 diabetes, um, it's pretty easy to control. You have to take either a pill or give yourself a shot of insulin every day to keep it in good control. But insulin can be $100 for a pen of like 3 milliliters of insulin, or $300 for a vial of 10 milliliters of insulin. And so that cost can be astronomical for somebody, especially if they're uninsured. And so what people tend to do is they don't fill their scripts and they don't take insulin because it's so expensive, so prohibitively expensive in some cases, and they go without. And then what can happen is you can get complications from diabetes like loss of vision, um, ulcers on your feet, or like abscesses on your skin. And so you could need to be hospitalized for an amputation or an abscess drainage, or you could lose your eyesight. And these could cause all the other problems like falls and injuries and things like that. And so, one condition and one medication that we're able to get insulin for free for some of our patients. And so, um, I've given out, I probably today alone, I probably gave out $2,000 worth of insulin for free to my patients. And that's going to last, those four patients about 3 months a piece, where they can control their blood sugar and have peace of mind around that. And it's going to save our health care system in our country multiple thousands, maybe tens of thousands of dollars in terms of downstream costs, in terms of preventing a hospital admission for like an abscess formation. That's just one condition. The other thing, people don't control their blood pressure because one, they don't want to know their numbers, and then some people might know that it's high, but it's too much of a hassle to see a doctor and get the scripts filled, and that they're unsure about the cost. So then, we fill people's blood pressure medications for 30 or 50 cents or sometimes $1 for like a 30-day supply. And then they have the peace of mind that they have the right medication, they're taking the right dose, and it's controlling their blood pressure. And high blood pressure is known as a silent killer. So it may not harm them for 5, 10, or 20 years, but if you go untreated for long enough, it's going to increase your risk of having a heart attack or a stroke. And so, if we treat 20 people and we prevent one heart attack or one stroke, that's a tremendous savings for the system as a whole.
Great. And I have a question of cost related to that, especially I recently read the book that you published. I got it from Amazon, and
Oh, wow. Thanks, man. It's
yeah, no
really kind
problem.
of you,
I
man.
really liked it. And one of the things that really surprised me were how astronomically lower your costs were. And you just mentioned now that you gave out around $2,000 of what would have, if someone bought it elsewhere, insulin. How do DPC practices buy at cost, and why is it so much lower? Um, and yeah.
Yeah. So, every day I'm asking myself, how can I provide more value to my patients? And so one of those ways is I can get people free insulin by writing basically a letter to Novo Nordisk. So there's something called Novo MedLink, and any doctor with an NPI number can go on a Novo MedLink and order free insulin samples for their patients. And not most doctors don't do that because they don't have the time, or they don't want to be able, you have to track the expiration date and the lot number and all that, and you have to store it in a refrigerator, and then you have to dispense it and keep track of it that way. But we're willing to do that for our patients because their health matters to us, and we can save people a ton of money. And somebody might pay us $49 a month, and we might give them, $1,000 worth of insulin every 3 months. So it makes the membership totally worth it for them. So we try to provide a ton of value. The other thing that we do, let's say for the blood pressure meds, is we wholesale, let's say, a bottle of 1,000 tablets of amlodipine, and that bottle might cost $9. And so then we're giving, these amlodipine 5 milligrams out for essentially zero point 0.9 cents a pill to our patients. And that's a huge cost savings for them. And it's something that's easy for us to do. But if you go to the pharmacy and fill that medication, it might be 10 or 15 or 20 bucks. So it, we're able to do it because, one, we leverage the free market. We buy medications at cost, and then we give them to our patients at cost. And then two, we're able to look for other resources, patient assistance programs, where we can help our patients get through, some tight spots with like medications or services that would be difficult to access it unless you had to work for it.
And especially when it comes to keeping these costs very low, um, do most direct primary care clinics have the same practices when it comes to cost, or are they all, completely independent in keeping a certain drug a little higher if they want to, or is it that just Plum Health that does that? And from what I've read online, it's a very active and kind of joint community in a way. And has there been more coordination within clinics to try and find different ways to keep prices low? How has that worked so far?
Yeah, sure. There's definitely a community of direct primary care doctors. I attend 3 conferences every year with DPC doctors. There's a direct primary care interest group through the American Academy of Family Physicians. And then we also have like a Facebook group where we all share best practices. And so, if somebody is wanting to figure out how to get somebody a sleep apnea test, they'll share what they found with the group, and then we'll learn from them and apply it in our own clinic if we can. Now, for some states like Texas and New York, doctors aren't able to dispense medications out of their own clinics. So that puts up a little bit of a barrier for those DPC practices. However, in Michigan and I think like 45 other states, you can dispense out of your clinic. So that's just another piece of value that we can provide. And so I think most direct primary care practices operate similar to how I operate. There's always going to be little idiosyncrasies and little differences because these are all started by individual physicians. They're not really corporatized. And within that, framework, there's a lot of flexibility and little differences from doctor to doctor. For example, like the doctor I work with, Dr. Orlick, she joined our practice a year and a half ago. She does a ton of PAP testing and a ton of women's health care in our clinic. And I do less of that. And I think, I focus more on like men's health concerns because that's the sort of patient that's attracted to my practice. So it's really going to vary by the doctor's comfort level, what they're interested in, and the services that their patients request.
And do you think that as the DPC model grows more popular, do you feel like it's going to be something that insurance companies are going to try to adopt within their plans? Because obviously there is a part of direct primary care that you can't offer urgent care all the time, and so insurance is necessary for a lot of people. Do you think insurance model will try and take the DPC model inside that kind of practice to have more primary care since it does deliver better health outcomes, or do you think it's going to remain separate?
Yeah, I mean, I would hope that insurance companies would, I guess in an ideal scenario, an insurance company would recognize that one of their members has a direct primary care service in hand, and they might discount their insurance premium based on the membership of that individual in the DPC practice. Because we do save so much money on downstream costs by addressing things early before they become bigger problems. And so it would only make sense to for insurance companies to look at us favorably and give a discount to some of their members. But I'm not holding my breath. I don't think that's ever going to happen because insurance companies in the United States are there to make money, and they do that at any cost. And so, so one of the things that we've seen is that there's like there's a cap on how much in the profit percentage that an insurance company can make. They can only spend 20% of their costs on administration and compensation. 80% of their costs have to go to care. So what they've done is they've inflated the cost of healthcare overall so that they're spending more on care to spend more on administrative costs. So like the pie just gets bigger and bigger and bigger every single year. And we've seen an insane increase in the cost of healthcare overall, like 20%. Health care costs are growing far faster than the rate of inflation overall.
And I also wonder in terms of price and cost, even for the government for healthcare, because it ends up inflating state budgets for even things like education. And that's incredibly problematic, which is why I wanted to ask you, since DPC doesn't exactly count as insurance, I was just wondering, are there practices that find ways to include Medicare or Medicaid patients, especially in underserved communities? Is there any way that I don't know, is there any regulation or DPC that takes these patients in without the fee or at a lowered cost? How has this worked so far?
Yeah, there's a few things there. So first of all, let's talk about how a company or a government might incorporate direct primary care. And one of those ways is they might become self-insured, meaning they take on the risk of the patient or the employees in their group. So for example, if you're a school district, you could become self-insured and then contract with the direct primary care office. What would happen there would be if the direct primary care prevents downstream hospital admissions, ER utilization, urgent care utilization, then overall, by self-insuring, you're lowering the cost of your care and lowering your healthcare spend every single year and saving money. And so we have seen school boards do that, or different companies who are self-insured engage in that sort of risk calculation. They're saying, man, if we partner with a really good direct primary care practice and we're self-insured, we could save a ton of money on our healthcare spend. And a lot of companies have been super successful in that endeavor. All right, so that's point number one. Point number two, we take care of Medicaid patients and we take care of Medicare patients. We just don't bill or use Medicaid or Medicare. A lot of patients find that they get a lot better service through our office. For example, Medicare patients, they get great service from us. We make house calls. We have 1-hour appointments. We can do med reconciliation. We can call their other specialists and make sure that we're all on board with the care plan. And we can create this like smooth transition into and out of hospital systems and really give a fantastic level of care. And when you go see somebody who bills Medicare, they also have to see 2,000 other patients. So they're not going to have the same amount of time to deliver that level of care. In terms of discounting our service, we do deliver a ton of charity care. Every month we're giving away like $2,000 to $5,000 worth of care, and that's like 5 to 10% of our monthly operating budget. So that's a significant amount of money that we're giving back to the community. We've never sent anybody to collections, and we've never like just bothered people about their bill. If they're unable to pay it, we just forgive it and let it go, and we move on to the next patient who hopefully can pay us. And then we have like a student discount, and then we have a group discount for small businesses. So these are the ways that we're trying to lower the cost of care for individuals and groups in our community.
And from the conferences that you go to with DPC and from other clinicians that you talk about or physicians, um, is there in your book you also mentioned that you often talk about financial wellness as well, which is helping choose the right plan for them and that kind of thing. Is this a practice that's adopted across different DPCs as well? Is this something that's widely implemented, or is this just something that's specific to your practice?
Sure. I think to be successful in this model, the physician has to have a really good understanding of the health insurance marketplace and the challenges that people face in their health insurance and primary care services. And so, to be a great business person in this model, you have to have that baseline understanding. Like today, I was engaging in a conversation with one of my patients who's debating between keeping his HMO or going to a PPO. And so HMO is a health maintenance organization. You have to see a PCP, primary care physician, dictated by the insurance company, and you can't see a specialist unless the PCP dictated by the insurance company says so. So if you are not seeing a lot of specialists in your community, if you really only need excellent primary care, maybe you can buy that HMO plan as a sort of catastrophic coverage because it's going to be lower cost. And then you can use us for all of your primary care services that you require. But if you are requiring multiple specialist visits and you have a specialist that you love in the community and you don't want to lose that relationship, then definitely buy that PPO plan or that preferred provider organization plan. And with that, you can have that excellent specialty care. And then you're not going to need a referral for it from an insurance dictated primary care physician. You can still come see us for your primary care needs, and then go see your specialists that you need when you need them without a referral. The only caveat there is that's going to cost more money than the HMO plan. So every day I'm talking to one of my patients about these systemic issues that they're going to face, be it Medicaid, being uninsured, be it HMO, PPO, or Medicare, and everything in between, even like TRICARE for those former members of the military who are part of our practice. So there's a lot there. There's a lot to navigate. And if you want to be successful as a direct primary care doctor, you have to know about these things.
And moving the conversation a little bit more to both the physician experience as well as for the patients. Um, I've heard a lot that doctor burnout reduces significantly when they get to have more time with patients and less with billing systems. Um, do you think that now progressively more physicians are moving towards a model of primary care and independent practices and away from insurance, or is it, what's your view on that?
Sure. Yeah, I think if you historically you look at medicine in the United States, we've had a ton of independent primary care physicians in the 1950s, 1960s, 1970s, and the pendulum then swung towards managed care HMOs in the 1980s and 1990s, and now affiliation with large hospital systems where doctors feel like they need to be a part of a huge gargantuan health insurance industrial complex to survive. And I think the pendulum is starting to swing back towards independent practices. Now, I know not every single doctor is going to want to go out and hang their own shingle and start their own practice, but there's a ton of benefit that you can gain if you can run a successful independent practice. And that's really autonomy and more time with patients and doing it like on your own, practicing medicine on your own terms for the benefit of your own patients. And I think as more and more doctors succeed in independent direct primary care practices or independent fee-for-service practices, their colleagues are going to look at them and say, what are they doing? What can I do to get to that point? And I see that all the time. Doctors reaching out to me. This week, I sat down with a 70-year-old physician who has been, in the fee-for-service world for 50 years, and he wants to do direct primary care now at the end of his career because he can't do it anymore. He can't do fee-for-service medicine anymore. So he's looking at how he can transition to DPC and ride out the rest of his career in this way.
And so, in that sense, when knowing that doctors have a better experience with the care they provide, patients, they also have better health outcomes because they have a bigger follow through with medication, cheaper costs, and all of that. That there is in the general debate of pro or con DPC, in a way, from what I've been reading, an argument that says that even though the care is better, you are serving less people because the patient panel is smaller. So I'm really curious to hear what your perspective is. If you are in an underserved community, for example, offering much better, cheaper care that people needed, isn't it a problem that you cut the patient panel by a lot and several people may not be having, a physician? So I just wanted to see your perspective on that.
Sure. Yeah, that's a great question. I get that one all the time. The issue is that the way health insurance is set up in the United States, the people who get paid the most money are typically people who have great, like, white collar jobs. They're employed, they make a really good salary, and a part of their salary is a really good benefits package where they get like a platinum, Blue Cross Blue Shield, or really high level of insurance. And those people typically live in wealthy areas, like the suburbs of Detroit, for example. And so, in Oakland County, there's one primary care physician for every 600 residents. So doctors are logical people. They follow the money. They set up their offices in wealthy communities because that's where the best quote unquote payer mix is. The people with the best insurance plans give doctors the most money when the doctors bill those insurance plans. So doctors are smart, they're intuitive, they know where to set up their practices to make the most money. Now, the negative side of that, the negative part of that fee-for-service industrial complex is that underserved communities, poorer communities, are therefore medically underserved, because what doctor is going to set up a community in Detroit? What rational physician is going to set up a community in Detroit and bill insurance where it's greater than 50% Medicaid? And doctors complain that they lose money every time they see a Medicaid patient. Their reimbursement is so low that they actually lose money. And that's why you really you don't see a lot of private primary care offices in Detroit. And if you do see primary care offices, they're often FQHCs, or federally qualified health centers. So then my argument is there's a huge gap in the market for excellent primary care. We happen to deliver that. And because we don't bill or use insurance, we're not bound by those rules. We can attract patients who are uninsured, underinsured, very well insured, reasonably insured, whatever. And then our office is in the heart of a underserved area. And so now we're providing excellent primary care services to a community that previously didn't have a doctor. So now we're going to have 3 doctors in this clinic. So it makes a tremendous difference for our community by not billing insurance. And then you talk about the carrot and the stick. You don't have a lot of people choosing primary care because it's really difficult work. Some doctors say it sucks. It's really difficult to see 25 patients each day and give them the time, care, and attention that they need on every single visit. And it's almost impossible. So doctors are banging their heads into the walls, feeling frustrated, feeling burnt out. And imagine yourself as a rotating medical student, seeing this doctor who's like pulling their hair out, screaming to the telephone for prior authorizations. It doesn't really look like an appealing job. Like, oh yeah, sign me up for that. That looks amazing. Versus if you go hang out with a direct primary care physician like myself, we're typically pretty happy. I can take 30 minutes, 45 minutes out of my day to have conversations with students like you, and I'm still doing okay financially. It's like we're having a good time practicing medicine. doing it the right way, taking care of our patients the right way. I have time to teach the medical students and residents that rotate with me. And I come into work and I leave work feeling pretty good every day. And you can't put a price tag on that. And so I want to lead, teach, and inspire more medical students and residents to choose community-based primary care, because that's really fulfilling work. If you strip away all the bull crap of insurance and prior authorizations and all the things that are crappy about medicine that insurance companies have ruined, if you can do that really well on your own, taking cash payments from your patients, you can be super successful and have a fulfilling life and career in medicine. And that's the answer.
Great, thank you very much. And
You're welcome.
since we're talking about, the question was kind of related to the scalability of DPC and if it can actually serve more people, and seeing how in underserved areas there's barely the necessary care, and that's the importance of DPC there. You mentioned in your book as well that in 2017 you had the opportunity to go to Washington and talk about primary care. And I wanted to ask you a little bit more on the perspective of how could regulators help DPC grow more? Kind of what opportunities are there? What barriers are there as well for the movement? And what exactly did you go to talk about? And more of a perspective of how the government can take a role with DPC and healthcare.
Sure. Yeah, really simply, the government, especially the IRS, could clarify its stance on health savings accounts for direct primary care. There's some conflicting information in the Affordable Care Act and in the IRS tax code around using a health savings account payment for direct primary care medicine. And so part of the reason I was there was to help raise awareness that there's like these conflicting answers, and that if you sorted that out, it would make this sort of direct primary care practice grow faster. We could serve more patients and be more successful as an organization, as a loose organization of direct primary care physicians. And that's it. I think that's the biggest thing that legislators could do is clarify HSA payments, FSA payments. Right now, most doctors accept HSA and FSA payments. There's seems like kind of a handshake agreement that regulators are not going to enforce the IRS code and they're going to defer to the ACA. I haven't heard of any doctor being fined or censured for taking HSA or FSA payments. So that's currently how most direct primary care practices operate. But there's always that like little shadow of doubt in the back of our minds. And it would be nice to not have that like storm cloud kind of hanging over our head, so to speak.
Yeah, and another question, a bit more related to the pandemic this time. I'm sorry about this. Everywhere I go, most of what I think is, I hope I'm not going to read something on COVID or talk about COVID. But, it's hard not to come with a question.
COVID-free zone.
Do you think that, I imagine now, I mean, we're doing this over Zoom as well, and I imagine you're talking to a lot of patients over Zoom as well. How telemedicine in this way has kind of disrupted the practice. Do you think older people have shied away from having a consultation? Has it driven down costs for you in any way? How has this affected in any way the way you practice medicine?
Well, what we're doing is we're still seeing patients in the office. For a time, we went virtual only, but I called a lot of my patients and especially my older patients, and just made sure that they were doing well. And that's something that I'm, proud to do. Phone call is telemedicine, and a typical doctor cannot be paid via a phone call. But because of our membership model, we're just paid for our time. So, it could be a 5-minute phone call or a 20-minute phone call versus, if somebody has a disability or difficulty getting out of the house, that could be transformational for them, being able to access their doctor via phone or text or email or video visit, etc. So during this time, we've had a lot more interactions with people via text and email and phone call, but we're still seeing patients in the office. We ask that everybody wear a mask while they're here. And then if they're sick or having symptoms, we test them curbside. And then we get the result of that test 24 hours later. If they're negative, they can then come to the office for the visit. and that system's worked pretty well. And so far, our medical assistant, the other doctor that I work with, they've not gotten coronavirus, so it's been really good. We've been having really strict protocols, and that's kept everybody safe in the office.
That's very good. That's very good. And speaking of the facility of communication, since you have less patients, it's easier, and also you have more time to talk to them and understand them and know them. Um, how often for DPC physicians is kind of like to text a patient and tell them to take their medication, or a reminder, I don't know, maybe for something to not smoke. How often is this communication across all patients? And how has this changed? Have you kind of found a way to, are DPCs kind of automating that, kind of like automated reminders to do something? Or
Yeah, I'll put a Google Calendar reminder every week to reach out to certain patients that I know who are working on weight loss or exercise goals or smoking cessation. And, I try to follow up with people every week with that kind of stuff. It is difficult though. Sometimes that stuff gets lost in the sauce, so to speak, if you have a busy week. But, when I think about somebody in their journey, I try to text them and just ask how it's going. How many steps did you get today? Tell me about the foods that you ate today. How many cigarettes did you smoke today? The more specific you are, the more actionable it can be. So, and it's not accusatory. It's just like, how are you doing in this journey?
and do you know if no, a bit less related to the practice, but more of the general discussion of health outcomes in DBC. Do you know of any studies or perhaps research or any publicly available data showing that the change of health outcomes at a patient that was not with direct primary care and then to direct primary care? Do you know anywhere that I could find this for research or anything similar?
I know that there are a couple studies out there, and I don't know like the link off the top of my head of the journal, but I could send you that via email.
And in terms of data, is it common for clinics to, for example, I'm researching and I'm using publicly available data, but I don't have any clinic specific one. Is it normal for people to ask a certain clinician or physician if they have some kind of anonymized data to kind of analyze? Is that out of hand?
No, that's not really typical. I haven't really had anybody ask me like, give me your data on how your patients fare in your model. But what I
Because
can say is that, because I have fewer patients, um, I can, I know who my patients who are diabetic. I know who my patients are who have high blood pressure, and it makes it easier for me to be cognizant of their challenges. And, it makes it easier for me to work with them through their condition to help them get to that lower hemoglobin A1C for diabetes or lower blood pressure for my patients with hypertension.
I did find one study that I found one that managed to track the health outcomes from a patient pool from a DPC clinic and those from outside, and that had really like insightful information that I'm planning on using. And
Yeah, I know. I think there's about like 3 studies at this point, but DPC is a relatively new model, so that information isn't as robust.
I don't know if you still had time because this is a 30-minute meeting and we're past 45. Is it
Yeah,
okay if I ask a few more questions, or are you
I
off?
actually got to go, man. I actually have an appointment at 5 o'clock here, so I got to
No,
get
that's fine,
running.
not a problem. Thank you very much for your time anyway. And
Oh, you're welcome.
if possible, if you could send me the recording so I could keep the transcript and all of this.
Yeah, if it's okay with you, I'll put this up on my blog and on YouTube.
That's fine. And in a couple months' time, I'll send you the full paper if you'd like to have a read.
Yeah, I'd love to. Thank you so
All
much
right,
for your
all
time,
right,
man,
great.
and
Thank you very much. Take
have a
care.
great weekend.
You too.
All right, cheers.